Good evening. My name is Rich Mazzillo. I'm the Executive Director of the New England Hemophilia Association. I will be the moderator for tonight's webinar. The title of the webinar is Copay Maximizer and Accumulators, What's the Difference? The objective and goals of this webinar is to help you better understand what copay accumulators and maximizers are, what is being done to prevent them from hurting families in the bleeding disorder community, and what you could do if your insurance provider allows one of these practices to happen. Before we get started this evening, I'd like to go over a few webinar points and helpful hints. Tonight's webinar will last no more than an hour and maybe shorter than that. We welcome your participation and questions. Your audio will be muted by the system for the entire duration of the webinar. If you have a question, we encourage you to use the question box on the bottom right-hand side of your control panel. I will then pass these questions along to Colette at the end of the presentation. So again, if you have a question, if a question comes up, in the control panel, there's a question feature. All you have to do is type your question in there, and then I will read them at the end of the webinar. We are honored and lucky to have our presenter tonight. Our presenter is Colette Koulianos. She is the Senior Director Payer Relations of the National Hemophilia Foundation. Colette is responsible for project leadership, analysis, and the development of NHF's healthcare payer education strategies, policies, and programs, which includes the Comprehensive Care Sustainability Collaborative, also known as CCSC. Prior to her tenure at NHF, Colette served as the Executive Director of the Bleeding and Clotting Disorder Institute in Peoria, Illinois, a federally recognized hemophilia treatment center of excellence, where she developed and grew an in-house specialty pharmacy program that became one of the larger programs in the country. Colette has also served on the Hemophilia Alliance Executive Board of Directors, served as the chair of the National Payer Subcommittee, and sat on the Illinois Hemophilia Advisory Board. Colette, it's my pleasure to now turn it over to you.
Hi there, good evening, and thank you for taking time out of your evening to join us. I hope you find this information useful, and as Rich said, I will be glad to answer any questions at the end of the presentation. So my apologies, I'm trying to advance it, and it is not advancing. So do I have the screen now, Rich?
Yes.
Sorry, here you go.
Yep, there you go. Perfect.
Yep. All right. Sorry, folks. Okay, so what we're going to do before we get into the specific definitions of what are copay maximizers and accumulators, we're going to start at the kind of the root of the problem and identify these strategies that payers are using and why. So first of all, you have healthcare literacy, where the majority, sorry, folks, it's doing it again. Rich? Oh.
Yeah, there it goes. Yes.
Okay, I'm really sorry.
In the lower left, yeah, in the lower left-hand.
Oh, I see the lower left corner. Okay, I'll use that
as
opposed to my.
Perfect.
Okay. So in our country, the statistics show that only 9% of the U.S. population has a basic understanding of the healthcare terms, deductible, copay, coinsurance, and premium. And even though that number says 9%, I still challenge that, because when I have a room full of folks and I say by a show of hands how many know what this means, the folks that do raise their hand, when we drill down into that further, there tends to be still some confusion over what those terms mean. So it's difficult if they can't understand some of the basic terminology to understand what these other programs are or how to spot them or avoid them if at all possible. So, so I'm going to go through some of these basic terms with you. Deductible is what you have to pay before the plan picks up 1 penny, right? So if you're in a plan that has a deductible under $1,300, $1,400, it's probably a PPO, an EPO, it could be an HMO, there's many acronyms for the types of plans, but that deductible must be paid in its entirety before the plan picks up a penny, as I mentioned. Now, if it's a high deductible health plan, the deductible can go all the way up to $6,950 in 2020. So anywhere in between, there's different flavors of high deductible health plans, but it'll have to be over the $1,350 range, and it can go all the way up to $6,950. Again, first the patient pays the deductible, every dime of it, before the plan picks up, and then the coinsurance and copay kicks in. So if the patient is on a high deductible health plan that has, let's say, a $3,000 deductible, then they'll have to pay the first $3,000, and then the plan will start paying a portion. They call this the coinsurance phase, where the patient will pay a portion and the plan will pay a portion. Usually that's around 80-20. The plan pays 80, the patient pays 20. And then there's also copays. So at that time, there are copays on pharmacy, at the pharmacy counter, copays when you visit the doctor. Different specialists have higher copays. And once the patient meets their maximum out of pocket, then the plan begins to pay at 100%. Now, a lot of people think the premium, which is what you pay to get your insurance, is actually part of your out of pocket. That's not true. The premium is, in fact, the charge to get the insurance. Most folks that are on private insurance are employer-sponsored health plans. 63%, in fact, are on employer-sponsored health plans. That means the employer pays some of the premium for the plan, and then the patient pays a percentage of the premium. So once again, you understand these key terms, it'll help you as you're either advising patients on how to look at plans, or if you're a patient, on how to make sure what type of plan you're picking. So the question is, if choice is an option, what all should be considered, right? Again, it's important to understand those key terms that we just went through, because where the accumulator adjustment programs have the most impact is on high deductible health plans, and I'll explain that here as we go further. And the second part of the challenge is, and why employers and why health plans are implementing these programs, is because of high cost claimants. So I'm going to define the high cost claimants here in a moment, but what we know from the data, and these studies come from Milliman, we have studies from the National Business Group on Health, and several other national organizations that have done surveys asking employers what is their strategy to manage high cost claimant, or manage their claims as they move forward. And the vast majority, 77% here, say managing high cost healthcare claimants is the number one kind of focus as they move forward to the next 3 to 5 years. So we ask, what are high cost claimants? So by definition, a high cost claimant is anyone who costs the health plan more than $50,000 a year. I probably don't have to tell you that hemophilia costs more than $50,000 a year for most patients, especially if they're taking clotting factor prophylactically, or they're using, not taking, I'm sorry. So how it breaks out is it has to be at least $50,000 a year by definition. The actual average in our country is $122,382. That is the average of, if you were to take all high cost claimants and you put them together, they average around $122,382. That's 29.3 times higher than the average patient. So a non-high cost claimant, if you will. Only 1.2% of the population make up high cost claimants, but it counts for 31% of the spend. So if you think about that, of all the folks that they cover, all the covered lives, only 1.2% of the covered lives that a plan covers makes up for almost a third of everything they pay out. So of course, if you understand that, it makes sense why they would look for strategies that aim at high cost claimants. Now, if you take a further step and you look at hemophilia, if the national average is $122,382, the hemophilia average is we know over 275,000. There's some numbers that are much higher than that, others that are a little lower than that, but NHF uses the number at least 275,000 as an average cost for hemophilia patients. So you can see how much even higher they are than the average high-cost claimant. And what tops the list as high-cost claimants in our country is cancer, live births and perinatal, and blood disease, which of course we fall under. So health plans then are using strategies. They're implementing strategies to address these high-cost claimants. And they're doing what's called utilization management strategies. And there's multiple different strategies that they can deploy, but the ones that we're going to focus on right now are high deductible health plans. That's a strategy. And why is that a strategy? Because the theory is, if you're a health plan and you shift some of the burden to the patient, in other words, they have to pay a higher deductible before the plan has to pay a penny, then the patient is going to be a better healthcare consumer. The patient is going to be conscientious when they're making decisions, especially when they have to pay a lot of the upfront cost. Then they're going to use generics instead of name brands. They're going to shop around for, if they do have to have some sort of test, a CAT scan, an MRI, et cetera, they're going to shop around for the lowest possible cost. And they're not going to have tests that are unnecessary because they have the cost risk. And then, now on top of these high deductible health plans, which have been a strategy for payers for quite some time now, several years, they've now implemented these copay accumulator adjustment programs, which when you stack them on top of each other really is the recipe to break the system, if you will. So we're going to go into, again, I went through why plans were implementing high deductible health plans. What we do know is since their uprise, since they really started gaining in popularity, there's been over 160 abstracts and publications that have come out that look at the unintended consequences of shifting those front-end costs to the patient in the form of a higher deductible. And when a patient has a chronic disease like hemophilia, they will tend to forego services or tend to forego being adherent to their treatment, and therefore the shift happens. Their prescription drugs may be cheaper, but then their medical costs will be higher, right? Because there'll be more ER visits or hospitalizations, et cetera. And as I mentioned, there's many abstracts and publications out there. If you have interest and you're bored, you can find them on the web. But so again, then I mentioned now this rise in copay accumulators and copay maximizers, and that what they are is another way for the payer to shift the burden onto the patient, and they do so. And so let me give you the basic definition of what an accumulator is. It's important to understand that word. Accumulator is what the insurance company tracks as how much you've spent out of pocket yourself as a patient. So it's your accumulated out-of-pocket expenditures. And they track that until you hit your max out-of-pocket. And that way they know when they're responsible for the whole thing. And so your accumulator, again, reflects what you yourself have paid towards your healthcare costs. And if you have a high deductible health plan, and as I mentioned in my earlier example, if your deductible is $3,000, until your accumulator showed you spent $3,000, you would not, the plan wouldn't pay a penny. So under these copay accumulator programs, the health plan prevents drug coupons from manufacturers from counting against the beneficiary's deductible. Beneficiary meaning the patient's deductible or out-of-pocket maximum. So as in the past, where we were able to, as a community, patients were able to get a copay card from manufacturer. Many times, the very first of the year, you could use that copay card, get your medicine. That copay card paid not only your deductible, but in many cases, especially with these high-cost drugs, it could meet your co-insurance copay all in 1 month, and you'd be done for the year. No other responsibility for the patient. And so, again, the payer looks at this as, well, now the patient didn't have any skin in this game. They had no responsibility. So they're saying, go ahead and use the coupon, but once that coupon value runs out, your accumulator is going to only reflect what you yourself paid, and in this case would be nothing. So then you have to pay the whole deductible once you've exhausted that coupon card, you have to pay the whole deductible before the plan pays a penny. So then what's a copay maximizer? So the accumulator says, if we use an example, which I'm going to go into and show you a case example a few slides forward, but a maximizer, they also call it a variable copay program. The plan actually increases the copay amount for certain specialty drugs. So if they chose to put hemophilia drugs into this, they actually have to change the plan. It requires a plan amendment, which is a lot more tedious for the plan. And it's only for a select group of drugs, usually 50 to 75 drugs or drug classes. And so then if the drug you were on had a $12,000 coupon, or if the drug you were on had a $15,000 coupon or a $20,000, they would take whatever the value of that coupon is, divide it by, 12 months, and that would become your new copay for just that drug. And so therefore, you use that coupon every month for the whole year. You get to access your drug, but it still doesn't count to your accumulator. So in the case with the maximizer, you'll at least be able to get your medication with the accumulator. If you don't have the deductible amount, you would not be able to. And when I go through the example, this is going to make more sense. So when I look at these, I'm really broad stroking this, but just for the sake of being able to show you where the high deductible health plans really are impacted. With all health plans starting in 2020, the ACA maximum out of pocket for an individual is going to be $8,150. For a family, the maximum out of pocket is $16,300. Now, for a high deductible health plan, your individual max out of pocket cannot be more than $6,900, and the family max out of pocket can't be more than $13,800. Now, there's health savings accounts that you can have with a high deductible health plan where you can put money in pre-tax, just like a flex plan or cafeteria plan. You put money in pre-tax, except you don't have to spend that money that year. If you don't spend it, you get to keep accumulating it. And so it's an IRS benefit, if you will. It's tax-free, put the money in. But there's caps on how much you can save in your HSA. So if you're on a high deductible health plan, and assuming you have an individual max out of pocket of $6,900, the most you can save in your HSA for an individual is $3,550. So still far short of the amount that the patient would need to hit their max out of pocket. So again, where these kind of really hit our community is where the copay accumulators hit the high deductible health plan. We know that 43% of individuals with private insurance in our country are on high deductible health plans. In 2017, more than a third of employers only offered high deductible health plans to their employees, so an employee didn't even have an option to choose something else. And as I mentioned, in order to qualify as a high deductible health plan for this coming year, it has to be $1,400. And if it's not a high deductible health plan, the max out of pocket, which I already went through, and those numbers were not updated. My apologies. It's $8,150 and $16,300. This just tells us the implementation of the copay accumulators and maximizers. How many have implemented? As of 2018, there were 28% of payers had implemented copay accumulators, or copay adjustments, I'm sorry. Another 16% said that they're available, but they haven't implemented them. And then between the copay accumulator and maximizers, an additional 6% implemented and planning to implement. This number here is scary because in 2019, another 8%, and after 2019, 19% have said, which obviously we're going into year 2020. So the numbers are staggering. We suspect it's over 50% of health plans have implemented either copay accumulator or maximizer. And here's some data that if you're part of the treatment center side of patient care and you're talking to payers or you're the patient and you're talking to your own employer, you know, the median household income in our country is $61,372. More than three out of every 4 U.S. workers live paycheck to paycheck, okay? And 2 out of 3 Americans say they don't have enough money for a $500 emergency. So when you take that information and you look at what our individual max out-of-pockets are and our family max out-of-pockets and the ceilings that are put on health savings accounts, even if you could save the full amount, you can't save enough to cover these kind of high out-of-pocket costs. So that's where the problem lies, especially with hemophilia patients, where this is not a like-to-have drug. This is a need-to-have treatment. So we're going to go through a patient scenario here. And this is where I said I think it'll start to come around and make more sense, I hope. But we're going to use this example. So we're going to assume patient's name is John Doe. We're going to assume he has hemophilia and that he's on a high deductible health plan. Now his deductible is $5,000 and his max out of pocket is the same. So once he hits his deductible, the plan pays 100% on my example. And just for the sake of making this easy, his monthly drug costs, we're going to say, in a perfect world, this will never happen, but it's $20,000 for his monthly drug costs. And we're going to say he has access to a manufacturer copay card that has an annual value of $15,000. Okay? So keep this in mind. So now, in the first scenario, this is, remember, back in the day when we didn't have copay accumulators and maximizers, which wasn't that long ago. That was before 2017. So before these trends started, this is how it would work. In January, let's say the patient calls, John Doe calls the pharmacy. Patient, remember, his drug is $20,000, and he's got a deductible of $5,000, which must be met before the plan pays any. And so they take the manufacturer coupon, right? And they apply this $5,000 that they owe from the coupon to the cost of the drug. The insurer now pays $15,000, right? Because $5,000 was taken off, and the patient's deductible now is $0. The patient has no out-of-pocket responsibility in this scenario, and from then on, for the rest of the year, from February through December, the patient has no out-of-pocket responsibility. Every single month, the patient would call in, order their drug, and let's say again it's costing $20,000. The plan pays 100% of the rest of the drug that year. Now, assuming there's no other medical costs and there's no other drug costs for the year, then the total cost to the patient that year was nothing. The total cost to the pharmaceutical company, right? They had a $15,000 card, but they only used $5,000 of it because once that was met, it wiped out the patient responsibility. And for the rest of the year, the insurer paid the rest. So in this case, the insurer paid out $235,000. Okay. Now, in the second scenario, we're going to say this now an accumulator adjustment program has been implemented. Okay, so same scenario, John Doe. In January, he calls the pharmacy. He orders his prescription. It costs $20,000, remember? And they take that manufacturer copay card that's $15,000 value, and they apply $5,000 to the member's deductible. They dispense the medication. The plan pays $15,000 because that's what's left. And the patient's deductible, remember, because his accumulator is what he paid. So it shows he didn't pay anything himself. So the patient's remaining deductible stays at $5,000. So come February, patient needs his drug again, $20,000. The pharmacy uses another $5,000 from the manufacturer copay card because remember it had $15,000, so there's still money left. They use $5,000 from the card. The insurer pays another $15,000. The patient's deductible, again, the accumulators reset. It only reflects what he's paid, which is nothing, so he still owes the full $5,000. Okay, so in March, patient calls, needs their meds. There's only $5,000 left on the manufacturer card, right? Because they've used $5,000 January, February, now it's March, $15,000, it's going to be gone. The insurer pays their $15,000. The patient still shows a $5,000 deductible because they didn't pay anything. This is where the problem lies, because now after March, the manufacturer copay card's exhausted. Come April, the patient's cost share at this point. They have to pay the full $5,000 at the time of the order, because remember, the plan doesn't pay a penny until the patient meets the deductible. The patient pays the $5,000. The manufacturer costs nothing because they've used all the card. The insurer pays again $15,000 that month. Now, if the patient could in fact afford that $5,000, it would show now their deductible is zero because they've now met their max out of pocket. And for the rest of the year, the plan pays $20,000. So if you look at the end scenario here, the total cost of the patient is $5,000, whereas you remember from the previous slide, the total cost of the patient was nothing. Total cost of the patient $5,000. Total cost of the pharmaceutical company now is the full $15,000, the whole value of the card. Where here, the total cost of the pharmaceutical company was only $5,000. And then the total cost to the insurer is $220,000 here, whereas with no accumulator or no maximizer, the total cost to the insurer was $235,000. So in that first year they implement that copay accumulator, the health plan looks like they saved $15,000. So this is why this looks enticing to them, okay? So we'll go into the maximizer for a moment. So now remember, I said on the maximizer, they take the value of the coupon and divide it over 12 months. And that way there's never going to be that cliff. Like in the previous example, in April, if the patient didn't have that $5,000 to pay, the patient would not be able to get their meds. So they hit this cliff at the end of March when they had used all their card. But in the maximizer example, they take the manufacturer coupon. It's $15,000, remember. They divide that out by 12 months. And so now they're going to make the copay for this member on this drug only $1,250 a month. And they're going to use that manufacturer copay card every month of the year. And they're going to allow that to pay the copay so the member can get their med. There's never going to be a cliff. The member will get their med. But notice here, the patient's deductible remains $5,000 every month because none of that money that was applied to the copay gets to count to the patient's deductible or their accumulator. So in this example, the total cost of the patient in this example is zero. Again, assuming there was no other medical costs, no other tests, no other drugs needed. But if there was other medical costs and drugs, they still would have had to meet the full $5,000. It's just in this example within a maximizer, if you are on a maximizer, you will at least get your medication. Whereas in the accumulator example, you could be forced in a situation where you just simply couldn't get your medication. So in this case, the total cost of pharma is $15,000 again because they used the whole value of the card. The total cost of the insurer is $225,000, and the patient's left with the deductible, the whole $5,000. So for any other services or tests or anything, they're going to have to meet that whole thing before the plan will pick up a penny. So if you compare the scenarios, in example one, that's without an accumulator or maximizer, no cost to the patient. Pharmaceutical, out of a $15,000 copay card, they only used $5,000 of it, and the total cost of the insurance was $235,000. Patient was left with no deductible, and so any other medical costs, tests, procedures, drugs would be no cost to the patient. Scenario two, there's a $5,000 cost to the patient, $15,000 cost to pharma because they use the whole card. So you see here $15,000 savings to the insurer by doing this, and the patient is left then after April with no deductible if they've met that amount in April. And in scenario three with the maximizer, you'll see here, and really this is the column to pay attention to, the total cost of insurance is $225,000. So it's still $10,000 cheaper than without either of these programs, but they save the most, if you will, by going with an accumulator adjuster. But in the accumulator adjuster scenario, the unintended consequences to the insurer far outweigh the risk of the patient ending up in the ER or the hospital because they weren't able to access their medication there when they hit that cliff in April. So here's where I'm going to let you guys ask some questions, and then I can talk too about where, what we've done and where we are in our country as far as some states do have, I'll tell you, Virginia, West Virginia, Illinois, Arizona have copay bans, copay accumulator bans. And that is if there is not a generic alternative, there's a ban on using them. However, in those states where there is legislation, the authority of the state to implement legislation only counts for commercial, fully funded commercial plans and marketplace plans, not employer self-funded plans. And 60% of all employer-sponsored plans are self-funded. And so that's governed by ERISA. So the state laws don't impact, unfortunately, they don't help when it's a self-funded plan. And we did get some legislation passed on a national level. It was actually the NBPP Final Rule 2020, which is the National Benefit Payment Parameter Rule that CMS and CSIO put out every year as additional kind of rules governing around the ACA. In June of this past year, they issued the NBPP Final Rule 2020, which said there was a ban on copay accumulators if there was no generics, and that affected all plans, including ERISA plans. However, unfortunately, in August, CMS and CSIO walked back the legislation because the people that are proponents of these programs said that it was a violation of the IRS HSA guidelines, and we're challenging that. We've been back, and as NHF has, and then we started a national coalition that now has 60-some patient advocacy organizations involved, and we've been back talking to CMS, CSIO, Department of Labor, OMB, and we're trying to get them to re-implement that ruling. However, we don't have an answer yet. We hope to have one by the end of November, but we don't, and we know that they're not going to enforce it in 2020. So, so that's the downside. But we're not going to stop until we get some resolution on this, both on a state and a national level. So I'll go ahead and let you guys ask away with your questions.
Great. Thank you so much, Colette, for that informational and eye-opening webinar. For those that are on, we do have a handful of questions in the queue. Just as a reminder, if you would like to ask a question, you go to your GoToWebinar control panel in the bottom right-hand or left-hand side of your screen, wherever that control panel is, and you just type the question in, and then I will read it out loud. The first question that came in, Colette, is why are the majority of the general population not educated on health insurance terms like these? Who influences their beliefs and knowledge, and how can we change that?
Well, that's a really good question, Rich. We try in our community, I think, Rich, obviously, I've said all along, and I will say it till my last breath, I think NEHA is one of the, leaders in our country as far as chapters and being like an amazing organization that does a lot of great educational events. But we have a lot of good chapters in our country, and they all work with their patient communities and offer educational programming that have to do with insurance and insurance topics. We have a toolkit out there just generally across the country. I think our community is more educated than most, but I still think there's so many terms and things change constantly. And when you look at something like a copay accumulator adjustment program, the problem is these insurance companies, they use tactics like changing the name of these programs to be something that sounds good for you. For example, United Healthcare called it the total out-of-pocket benefit maximization program. And we have total out-of-pocket protection program. And I mean, those sound like something the patient would be happy to have, but in fact, it's actually the opposite. And so they use deceiving, in my opinion, terminology, and there's so many acronyms like in our world to begin with, but specific around health insurance and plan types. And I just think it's hard for most people to follow. Even people like us who do it all the time can get tricked up by some of the terminology. So I don't know if that answers the question, but I do think the hemophilia community is probably better off than a lot of patient group communities, but we still have a lot of work to do.
Great. Thank you, Colette. The next question is, Colette, thank you for such a thorough and accessible webinar. I'm struck by the 91% or more health illiteracy statistic that you used to level set at the opening. Are there resources that you know of that you can share or that you can share that we can share with communities to improve self-education?
I mean, we do. I mean, NHF has a toolkit, and it's got, like, for example, it's got a glossary that goes through like all the acronyms, like way more than the 4 I mentioned. And so it is a good resource, and I would recommend sharing it. And I know that there's some HTCs out there that have put it out on their website. I think that even if anything, the glossary page in there, and I'm happy, I have some definitions specific to really this topic that, talk about the specific health plan types, and then, the definitions of accumulator and maximizer that I'm happy to share with Rich, and he can share out as well. But, I think those are the tools that come to the top of my head right now.
Great. And we can certainly send that link out in the follow-up email when this recording goes onto a space where you can access it. The next question is, what do you have to do to ask your insurance company and or find in your insurance plan if they have and are using the accumulator or accumulator maximer? Is there a way that you can find it in a plan while you're researching it, or if your insurance company rolls it out, what do you do to ask the insurance company and or find one or find it?
So, tough question, because like on the marketplace, if you're looking, it is so difficult to actually get the plan, the full plan language, until sometimes you actually choose your plan. If you call half the people on the phones, I think they read from a book, like a predefined, dialogue, and you'll get different answers from different folks at the same company. And then, it's a conundrum for me, because when we went and met with CMS and CSIO, and we talked about specific marketplace plans, and we said, some of the folks at the table were saying, we need to make sure that this is very obvious, that it's on the front page of the deck sheet, and that anyone looking for a plan gets the very clear definition of what this means and what they're getting themselves into. And I sat at the table thinking, I don't know about that. I'm not sure. And here's why. Because as an example, in Texas, there were 4 or 5 plans on the marketplace in this one region. And 3 of the plans had accumulator adjustments, very clear on the front page this past year, 2019, when they were choosing their 2019 plan year. 2 plans didn't. So guess who all the chronic disease patients chose? They chose those 2 plans. One of the companies pulled out of the market, and the other one threatened to. I'm not sure if they ever did, but what that'll do is bankrupt. If every hemophilia patient picks the only plan on the marketplace that doesn't have an accumulator, it'll bankrupt the plan. So I wasn't sure that was the way we should go about it. I want to make them go away. Like, I don't want a Band-Aid. I want to make these go away. And so that's where I'm coming from. In the meantime, it's important that you understand that a lot of national payers, once we get a chance to talk to them, because I'm very engaged with employers, I'm working on with the 50 state and regional business coalitions across the country and the national business coalitions that are the voice of the employer community. And I've had opportunities to speak at many of them, do webinars for many of them. And when I talk about what this really means for hemophilia and the unintended consequences, meaning the patient doesn't have a choice. they have to have their meds. So if they hit that cliff in April and they can't pay that $5,000, because remember, I shared the facts, right? 3 out of 4 Americans, paycheck to paycheck, you know, whatever. 3 out of 4 people don't have $500 in emergency. They can't hit that. They can't pay it. They're left with no option but to go to the highest site of care to get treatment. And so it's going to cost the health plan way more money downstream in that scenario. And employers will go, I get it, that this isn't good. We've had some employers that have put the drug on the preventative drug list, which is outside the deductible. That's similar to the copay maximizer because it helps the patient get the drug, but it doesn't meet their out-of-pocket responsibilities for their other healthcare costs. And so while I don't like the maximizers either, in theory, if I had to pick which is the worst of 2 evils, the accumulator's worse because patients could be left with an obstacle to getting their drug, whereas the maximizer, they're going to get their drug, they're just left with an obstacle to get other medical treatment and services. And so for me, you know, if I can't, you know, I'm going to fight the fight, but I'm going to go for the biggest problem first. So.
Great, thank you, Colette. Next question that we have is, could you comment on NHF's position on deductible spread to allow patients to pay their deductible over the 12 months?
Well, you know, there's organizations out there that are doing some sort of like loans, if you will, to patients, no interest loans even, and some plans that are allowing some of this. The problem is, if I go back to the facts, you know, the $61,372 is the median household income and $500 for an emergency. These are costs. It's unlike the, you know, this is John Doe. And so the employers will argue, well, it's not fair because Jim Doe, you know, he sits in the cubicle next to John, and Jim has to pay all his health care costs. He doesn't have a coupon from a manufacturer to meet all his out-of-pocket costs. And, you know, and I argue that because John Doe has this every single year, January, he's going to have to pay the entire thing because his drug costs are so high. There's no possible way that he isn't going to hit that every year at the beginning of the year. And so you can spread these loans out over periods of time, but it's just going to start stacking on top of each other. The system is broken in this example. And that's no different really than the maximizer program because it does spread it out. It allows the patient to get their drug. But then when you want a lab test or some other medication that might be a lower cost, you know, small molecule drug, or you need an x-ray or whatever, you're going to be more conscientious before you do those things. You're going to make sure that you really need it, and you're going to price shop. And that was the whole intent of the programs. And so, but I do want to throw in, here's where I'm going to throw this in. All the employers, all the health plans to date, I've heard none that have challenged this, will accept third-party nonprofit assistance if it's from an organization like PAN Foundation or the Assistance Fund or PSI. However, PSI, while they're great in their premium assistance, they do not have copay assistance at this time for hemophilia. But PAN Foundation does, and the Assistance Fund does. And both of those organizations, if you qualify, so if the patient meets the income qualification, which is, you know, at or below 500% of federal poverty level, which is really not, I mean, the dollar figure is not so low. I mean, it's well over $100,000 they can make if they have a family of 4, and then they don't count bonuses or other incremental dollars that come in other than their salary. And so if they qualify for those dollars to get the copay assistance at the beginning of the year, that counts to the patient's accumulator, and we don't have this problem. So I would definitely advise, if you're, talking to patients about this, if they are hit with this, to try that route to get the assistance. Unfortunately, they don't have BWD funding yet. They have agreed to open a BWD fund if they got some pharmaceutical companies to donate, but there is hemophilia dollars in the copay funds for both Assistance Fund and PAN Foundation at this time.
Great, thank you, Colette. This question, I'm going to paraphrase here, but I am currently, says this question, I'm currently on a plan where I do not believe the accumulator adjuster has hit it yet. The way that my manufacturer co-payment assistant works is I get reimbursed through a third-party vendor. Can accumulators adjusters hit me as well in this scenario?
So that's a really good question for whoever posed that question. I'll tell you that, so I'm going to give you the answer is if there's some way that the manufacturer is paying after the fact. In other words, if you yourself are paying the bill and then you're getting reimbursed from the manufacturer, or they're giving you some sort of a debit card type of scenario, which we've heard of these things, then it's likely that you could, quote unquote, get away with it, even if they have a copay accumulator. However, I would challenge that to circumvention of plan design, which is the whole thing employers are against. And we've had patients across the country, only a handful so far, but the number has grown every year, that have been asked to sign a letter of attestation at the end of the year from their employer saying, I did not receive any assistance whatsoever from a manufacturer to get my medication. And, you know, they list the medication. And if you lie, you could lose your insurance. You could technically go to jail. You could owe the money back. Not just that money, but like how much the drug cost. I mean, and our fear at NHF is also the risk, does the patient then get is that taxable income if the patient is remunerated? And so, you know, I've talked to pharmaceutical companies that do pay it back in some capacity. And, you know, I'm sure they have much bigger resources, and they say at this point, they don't believe it's any violation. But when there's an attestation asked, we are reticent to recommend that that's a route to go. I'd much rather make these go away. But I also want to make sure our patient community gets their medication. So, you know, you have to make that decision. Now, if it's a third-party nonprofit that you're getting the help from, not a problem. They're okay with that as long as you went through some needs-based testing and you got the assistance because you truly needed it, not it's offered to everybody and it's one manufacturer offering it to everybody regardless of their means, and it's only for their drug.
Great, thank you. This is the last question that we have, so if you haven't asked a question yet, please fill it out into the question box. We could probably take one or two more. But this question refers to the CMS ruling that you mentioned. If the CMS comes out in favor or against, can we see hypothetically in 2020 this meaning accumulator adjuster is being banned from insurance plans, or do we see the trend of this continuing to happen throughout the next couple of years?
So if the CMS CSIO comes back and takes back up the position that they're banning the copay accumulators both on the ERISA plans and marketplace plans and all private insurance, it won't be enforced in 2020. We know that already. It would be part of NBPP 2021. And so that would not go into effect till January 1 of 2021. So if they came out and say that they're going to go back to the original language, that doesn't start till January 2021. If they say that they're walking it back permanently, you know, then we still have time this year to fight, and we will. And just like we got it passed and then they walked it back in the middle of the year, it isn't over till it's over. And so we'll continue to challenge this throughout the year. So the best I can say is I know it won't be 2020 that this will be enforced on ERISA plans. But if you live in one of those states where there's copay accumulator bans and you're on a marketplace, then you're good. Or if you're in a fully funded commercial plan, and other states are interested in passing legislation. So there's several other states that have introduced legislation, and hopefully we'll have more to report out as the year goes on.
Great. 2 more questions came in, and then if there's no other questions, we will conclude the webinar after these 2, Colette.
Okay.
The question is, how can other patient advocacy organizations sign on to the coalitions against accumulator plans, which you mentioned NHF is leading?
Well, NHF is one of the steering committee founders. There's NORD and Arthritis Foundation and HIV, AIDS, and MS, and cancer. Are all on the steering committee, and like I said, 60-some organizations. So from a chapter, from a state level, you can join on it's called All Copays Count Coalition. And, you know, even from a center standpoint, certainly, you know, if you're part of a treatment center and you want to get engaged, you know, go to the All Copays Count website and sign on to get involved. So.
Great. And can you give that website one more time?
It's All Copays Count. I believe it's .com. I'm looking it up right now as we're talking. I'm sorry. It's late. Let's see. Well, I'll have it here before we're finished. Go ahead with your next.
Okay. All right. Perfect. Thank you. And the last question is the work that states are doing on advocacy/legislative days on a local level helping to stop these from helping to stop insurance plans from implementing them? And if not, is there anything we can do on a local level during advocacy legislative days to talk to our elected officials about these harmful practices?
I'm sorry. Repeat the beginning part of this. I caught.
Sure. Sure. Yeah. Is the work states are doing during, you know, for example, NEHA advocacy days in Massachusetts or other state advocacy days, helping to stop these from getting, you know, from insurance plans from implementing them? And if not, is there something that local individuals can talk during these advocacy legislative days to the local elected officials about accumulator adjusters and maximizers, or is this all with federal?
No, it's definitely, you have the ability to impact on a state level. And I mean, if any chapter in the country is engaged on certain NEHA is, but when NEHA does their legislative days, or if they're done in various states as opposed to NEHA, I don't know how that works in your region, but yes, get engaged in those. And yes, you can have this dialogue with your legislators. You know, it's one of those things that's been nonpartisan from a state level. Once you explain the scenario, legislators on both sides of the aisle have been more than happy to kind of take up the fight. I will tell you, there's been fierce opposition. The first state that we finally got, you know, when I was there lobbying and speaking to legislators about this for 2 days before the vote, and AHIP, which is America's Health Insurance Plans, was there in force and very vocal against making any state legislation. But we still, like I said, we've had some success in those states, and you can do it in your area, you know, and that's where you can make a difference. The problem is those states cannot affect ERISA plans. So if you're on a self-funded health plan, meaning your company is not only helping with the premium, but they're the ones who are taking the risk. They pay all the claims. They may use United Healthcare, Blue Cross Blue Shield, or Anthem, or whatever, to act as a third-party administrator. They use their network. They manage the claims for them, but the employer's paying the claims. The state does not have jurisdiction to govern ERISA plans. That is a federal deal, and a whole different beast. But you can make an impact on marketplace plans and fully funded commercial plans.
Fantastic answer. Thank you. Thank you, everyone, again, for attending tonight's webinar. Our recording in its entirety will be added this week to our YouTube channel and then be shared also with all of the attendees who were on here. Throughout the year, we try hosting webinars that are educational, always in partnership with organizations like NHF or HFA or other community speakers about topics that are coming up in survey results or needs assessment, and this was one that certainly did come up. To see the upcoming NEHA event in 2020, you can go to www.nehemophilia.org. In the upper right-hand corner, there is attend an event. All of our 2020 dates are up there now with more information. A big thank you to Colette for taking time out of her busy schedule to do this webinar for us tonight. Thank you, Colette. It was incredibly helpful and is going to help a lot of us navigate this very tricky, muddy situation that unfortunately folks are finding themselves in. Everyone, have a great evening and happy holidays.
Happy holidays.